And I think we could give maybe another minute for people as they're logging in, and then we'll get started. How does that sound, Dr. Barnert?
Sounds good. Destiny, I think I did see your cat. Did your cat go off the table to the side? Yeah.
You're right there. Every time I talk to my Zoom, he decides that he wants to join in, so. Okay. So I think we'll get started as we have people logging in. So first, good afternoon, everyone. I'm delighted to introduce today's speaker and to moderate this discussion. First, on behalf of the SEICHE Center for Health and Justice, I wanted to thank today's event's co-sponsors, the Tow Youth Justice Institute at the University of New Haven, as well as the Connecticut Justice Alliance. Both organizations include amazing advocates, educators, and researchers for justice-involved youth, and we're really excited to collaborate with them today. Second, I wanted to make a logistical note. Throughout this webinar, all participants are going to remain muted. I will be monitoring the Q&A in the chat box for questions throughout this to pose at the end of the session. But if anyone would like to ask questions out loud, you can always use the raise hand function on Zoom, and I'll unmute you to be able to do so. And finally, I'd like to introduce our speaker. Dr. Elizabeth Barnert is a pediatrician and a researcher at the David Geffen School of Medicine at the University of California, Los Angeles. She received her medical degree and Master's of Science from the UC Berkeley UCSF Joint Medical Program, and she completed her pediatrics residency training at Stanford University Medical Center, after which she went to UCLA for the Robert Wood Johnson Clinical Scholars Program, where she earned a Master's of Public Health and Health Policy. She then joined the UCLA pediatrics faculty and her NIH-funded research partners with LA County to test an intervention that links youth to mental health and substance use treatment services after incarceration. She's passionate about giving children in crisis the resources and supports that they need to thrive, and this passion has helped to drive her work that has spanned researching the effects of family separation at the border, studying youth impacted by commercial sexual exploitation, and characterizing the impact of the juvenile justice system on children. And then she takes a step beyond research and has done work to reunify families, the subject of her upcoming book Reunion, decriminalize survivors of commercial sexual exploitation, and advocate for policies that remove children from the juvenile justice system to provide supports for their health and well-being instead. And I feel lucky to call her a mentor and a role model, and I look forward to learning from her today. And so with that, I'm going to hand things off to Dr. Barnert.
Thank you so much, Destiny, and to Dr. Wang and Tyler. It's such an honor to be here. I am going to share my screen now so that you can see my slides. Okay, and Destiny is my mentee, but even before the session, she was teaching me how to get this in proper view. So just a second here. Okay, now then I click swap displays.
Actually, perfect. Oh no, swap it back.
Okay. We're good. Yes. Okay. So I'm Liz, and thank you, Destiny, for that beautiful introduction. Today, we are going to be talking about what I call the concept of children in handcuffs. Is there a better way? And this is such an important question for America right now. Okay. So let's see. So I'm going to just start off by giving you an overview of the relationship between youth incarceration and health, which has been a big focus of my career. And very important, I want everybody to understand, everybody needs to understand these kids that we see in this picture, this is a health issue. This is a major public health issue that we all need to work together to address. So the juvenile justice system, as opposed to the separate adult criminal justice system, was founded in the 1900s, right at the turn of the century. And the goal was to protect children and offer treatment in the best interest of the child. And this is so important because I think we've gotten lost from this intention and the standard, and we need to get back to it. In the 1980s and the 1990s, the juvenile justice system became increasingly harsh and punitive and a get tough on crime approach. And then when I was starting to begin my training, my medical training research career, we really saw this movement of juvenile justice reform around the 2000s. That you would hear terms like rehabilitation, decriminalization, diversion, restorative justice, and there's been bipartisan support for this movement. And it has really been effective at chipping away at the juvenile justice system. And what has happened in the last year or two, I almost wrote it on the slide, but I'm not quite sure if it's ready to be in text. But now this movement is going even further, and we're starting to hear the term abolition, this idea that the juvenile justice system should not exist in the first place. Maybe that is what's needed for the best interest of the child. So that's a quick overview of the juvenile justice system's intention and where it's coming from. In terms of the detention process, for those of you who aren't familiar with it, what happens with youth, so mostly in most states, young people less than 18, they enter the system either through arrest, which is the more common mechanism, or through referral. So parents, teachers, or probation can refer kids to the detention system. And already through that mechanism, you can see that kids are already known to the system, are more likely to keep going back into it through the arrest or referral mechanism. The reasons for entering the system, only 5% have to do with violent crimes, 22% for non-violent property crimes like theft, and the vast majority are for low-level non-violent offenses. There have been a set of policies over the last decades, things like zero tolerance policies in schools, and what we call the school to prison pipeline, and more recently has been labeled the cradle to prison pipeline, which has been leading to large numbers of kids tracking into the system. In terms of the process, it usually starts with arrest or sometimes with referral. A child will then be detained, or after the arrest, sometimes the kid will just be home and then they'll have a court hearing. And then after the court hearing, they may be convicted. And if the outcome of their conviction could be house arrest, or kids could be sentenced to a residential facility. And one thing in terms of the facilities, we use a bunch of euphemisms for these different kids' jails. And in Los Angeles County, we call them camps. In San Francisco, they used to be called ranches. I believe in New York, they're called ranches. But these are the kid jails where kids are sentenced to serve their time. And then sometimes kids will also be sent to probation supervision where they'll receive community-based support. Once kids are released, they'll go home or to a group home placement, some kind of placement. And many kids, if they've had a conviction, will be under court supervision for a set amount of time. So it's kind of basic overview of the process. In terms of the epidemiology, so what is the scope of this issue? And I want to be clear, I'm using the term epidemiology very intentionally to remind us that this is a public health issue. So the numbers were huge. In 1996, there were 2.7 million arrests of youth in the United States. In 2017, because of that juvenile justice reform movement, the numbers went down. So there were 800,000 arrests of kids less than 18. And of those, 107,000 were detained and 78,000 were sentenced to out-of-home care. And importantly, 1 in 10 of these kids under 18 were in adult facilities. So these numbers are high. They're not as high as the huge numbers of adults in the system. So there are 6.6 million adults. These numbers are a little out of date, but huge percentage of US adults, about 3% of the population is under correctional supervision. And there's a strong connection between kids in the justice system feeding into the system as adults. About 80% of kids who are arrested, detained will then get into the adult system. So this is just a brief picture to kind of give you a sense of the timeline. So we see a major change in the trends around the 1980s. This is when our epidemic of mass incarceration really started with the war on drugs, mostly on the adult side in the prison and jails, but also on the juvenile justice side. And how are we doing compared to the rest of the world? So slides on this shows youth incarceration rate per 100,000 youth. And you can see the United States in orange. Destiny, can you see my cursor? Okay, so the US in orange is towering over all other countries with our youth incarceration rate. And the next highest is South Africa, and the lowest is Japan. Our rates have gone down a bit, but in the US, we do incarcerate a greater number and a far greater proportion of our youth than in any other country. And this slide, I'm just going to spend some time on it to let it sink in. And if you take away one thing from this talk, I would really like for you to remember this. There are huge racial, ethnic disproportionalities. So this slide shows lifetime imprisonment risk for white men. It's 1 in 17. For Black men, it is 1 in 3 in the United States. And for Latino men, it is 1 in 6. So this is the risk that if you are a Black man, the chance that you will go to prison at some point in your life is 1 in 3. And I think one thing that's so astounding about these numbers is that this is not an advocacy organization that was just kind of pulling numbers. This is data from the US Bureau of Justice Statistics. So there is clearly very strong racial disparities that exist for many different reasons, and is really showing a big problem that needs to be addressed. And these trends of disproportionality exist for women and also for kids in the juvenile justice system. The cost of youth incarceration, so incredibly expensive, and we spend about $5 billion per year on youth incarceration. The average length of stay for a kid is 3 to 4 months, and the average cost per stay is $25,000. So imagine what that money could do, if we put it to a school budget, for example. And then there are indirect costs of many billions per year. In contrast, some economic analyses have shown that if we were to invest in children and prevent a pathway of incarceration, we would save $2.6 to $5.3 million on one 14-year-old. So now I really want to shift this. I've at the earlier part of my career, the stage of the destiny is in now. I was really interested in trying to understand the health status of incarcerated youth. Kids in the justice system have disproportionately high medical and mental health needs. So I think it all begins with the social determinants of health, those social factors that influence people's health. There's a complex interplay between health disparities and the disparities that contribute to people ending up in the justice system. And taking that one step further, this study was really seminal in the field. It's looking at the relationship between adverse childhood experiences, or ACEs, and justice involvement. It was a simple study in Florida that just counted the number of ACEs kids in the justice system said they were exposed to. And it was compared to the data, the seminal study from the Kaiser Felitti study that looked at ACEs, and that showed that ACEs were connected to lifelong health outcomes, such as cardiovascular risk. And so what we see is that kids in this, we don't use these terms anymore, juvenile offenders, but kids in the justice system in Florida had a much higher prevalence of ACEs. So half of the kids reported 4 or more ACEs compared to this comparison group of a Kaiser insured population. And in terms of what ACEs, the kids were reporting a lot of ACEs. This slide compares females to males. And we see that girls had a higher prevalence of ACEs than boys. And also the kids were, not all ACEs are believed to be as detrimental, but it's notable that the kids were reporting very high ACEs of very serious things like sexual abuse. 31% of the girls were reporting sexual abuse, physical abuse, 40% of the girls, 26%, 1 in 4 of the boys. And this is consistent across the juvenile justice literature. It's consistent with my experience as a juvenile justice pediatrician. Kids in the justice system are kids that have a lot of ACEs, and kids that, they often need a lot of support. In terms of the medical needs, the biggest study on this found that 46% of kids who newly presented to justice facilities had urgent medical needs at the time of arriving to the facility. And in terms of what these needs were, 2/3 reported a physical health need. Very commonly, the kids needed the ancillary care like dental, vision, or hearing. Also, a lot of them had acute illnesses like acute upper respiratory illnesses. 25% had injuries. The unmet dental health needs are very high. So 6% had urgent dental issues. And then as well as kind of the general adolescent stuff, headache, belly pain, respiratory symptoms. Sleep problems are so common, and that has a lot to do with the conditions of confinement and how hard it is to be in a justice facility and kind of the schedules that we impose on the kids. And then a lot of the kids also, as with adults, have chronic illness that is undiagnosed or untreated at the time they present. These conditions like asthma, diabetes, and epilepsy. The reproductive health needs are extremely high. So 12% of incarcerated youth of both boys and girls are expecting a child. This is, you can see it's a picture of a pregnant girl. And the rates of teen parenthood are very high as well. So in terms of sexually transmitted infections, in the justice involved population, juvenile justice involved population, 13.5% of girls have chlamydia compared to 3.3% in the general adolescent population, and 6.7% of boys have chlamydia compared to 0.7%. And then in terms of parenthood, 15% of boys in the justice system are teen parents, and 9% of girls are, compared to national rates of 2% and 6%. 1/3 of girls who are in the justice system have been pregnant or are pregnant. Now, it's hard to talk about this properly and give it the right attention that it needs. But the most seminal, the most widely cited study by Teplin found that 75% of kids in the justice system have at least one psychiatric disorder. And this is a picture of a child in solitary confinement. Very commonly, the conditions like depression, anxiety, ADHD, learning disorder, what we call conduct disorder, PTSD, and substance use are commonly seen. A lot of these conditions might relate to why kids end up in the justice system in the first place, or things like PTSD might relate to the trauma of the justice system. There's inequities in mental health and in how we stigmatize children as well. I think that influences this kind of, I think there is some over pathologizing, but there's also a large amount of unmet health need and unmet developmental support as well. But in terms of the numbers, when you look at the prevalent study, I gave you that 75% statistic, but when you break it down by gender, 2/3 of incarcerated boys and 3/4 of incarcerated girls meet criteria for at least one psychiatric disorder. So essentially the girls have a higher prevalence of mental illness or mental challenges, and 27% had mental conditions requiring immediate treatment. And the rate of suicidality is very high. And I remember when I was first studying this, there is that first moment where it's surprising, because you think of that kids are in the sort of watched environment, so you think it will be safe. But the rates of suicide attempt and suicide completion are actually higher for kids in juvenile justice settings. 52% of kids in juvenile the justice system report suicidal ideation. 1/3 have a history of suicide attempts, and the suicide completion rate is 4 times higher than the general adolescent population. I did this little study that looked at kind of the lowest risk kids, or the earliest on the carceral pathway, kids who were the first time at juvenile hall and were expected to be sent home the next day. And even the rate of suicidality in those kids was strikingly high, higher than the general adolescent population. There's, again, I think there's a lot of unmet health need that really needs to be addressed. So in terms of mortality, kids who have been involved in the juvenile justice system have 4 times higher risk of mortality than their same age peers. 90% of the deaths are from homicide. The highest rates, or the highest death rate among the formerly juvenile justice involved young people is seen in African American boys, but the rates in girls of death are 8 times higher than their same age peers. There's also what we call we can think of as special populations. So people in the justice system who might have some intersectional issues that, worth paying attention to, that patterns of higher needs. So it's already alluding to the girls. We talked about their higher morbidity, these higher rates of abuse compared to boys. LGBT youth are particularly vulnerable. They have these higher risks for justice involvement. They're disproportionately confined. There's intersectional risk for LGBT youth who are of color. And then there's also unique challenges within detention facilities in terms of bullying, risk of assault. And then there's a lot of issues around transgender youth. What is the proper and safe care for somebody who identifies as transgender? There's also this concept of crossover youth, which was a term that was used, and these kids were talked about a lot starting about 10, 15, 20 years ago, I would say, or so. Crossover youth refers to kids that are dually involved. Sometimes they're called dually involved youth in both the juvenile justice and the foster care system. And surprisingly, we don't have good numbers on how many kids in the justice system are also in the child welfare system. But not surprisingly, there is a lot of crossover, and many of the kids touch both systems or go back and forth between the two systems. So in terms of the healthcare of detained youth, everybody has access to healthcare by law. So I'm not going to say that justice involvement is good for kids, but one of the benefits of being in the justice system is that young people do have access to healthcare. And it is a time, for example, when we get kids caught up on vaccines, as I alluded to, we get their chronic issues and their acute issues addressed. There are standards for the quality of care developed by an entity called the National Commission of Correctional Healthcare. That's what the NCCHC stands for. The NCCHC provides voluntary accreditation for correctional health facilities, but participation is voluntary, and we don't have national standards that are mandated about the quality of care. The American Academy of Pediatrics has AAP has some very great guidelines on the care that should be delivered, as does NCCHC. And then there are unique challenges to giving care in detention. Kids are scared, kids are hungry, you're kind of practicing within the house of probation. So probation is your gatekeeper. You don't have ready access to parents. So for kids with complex medical issues, that can be challenging. For any care that the kids need outside of the facility. So most facilities essentially just give basic care like a community clinic. And then if kids need more, then they go to their community emergency room, community hospital, or to specialists within, if it's a county system, within the county health system. Another issue to consider is reentry. So the rates of recidivism are very high. A lot of kids cycle in and out of the system. And one of the challenges I saw in Los Angeles County in particular, but this is a universal issue for kids and adults, is problems related to the Medicaid inmate exclusion. So if you don't know, worth mentioning, our federal statute that was passed in 1965 that established Medicare and Medicaid stated that anybody who is an inmate of a correctional facility cannot be covered by Medicaid or Medicare. So as a result, most facilities turn off Medicaid when people come in. And not surprisingly, we're good at turning it off, but not very good at turning it back on. So it's a situation where the system creates gaps in coverage for people who are very vulnerable, and particularly for justice involved individuals, for kids and adults. A lot of times their court plans, their conditions of probation require them to have substance use treatment, to have mental health follow-up, and sometimes that gets blocked with gaps in Medicaid. So this is an issue I'm very passionate about. This is a public health issue within a public health issue, and it's something bureaucratic that all rests in policy that really should be addressed. And we're making improvements. It's incredibly complicated, and it shouldn't be. We need to make success as easy as possible for people. Okay, so I'm just going to check on the time. So really briefly, I did a study looking at the relationship between youth incarceration and adult health. And now Destiny is working with me on a similar study where we're focusing in on the youngest kids. But just to kind of give you a quick visual sense, we looked at national data from Ad Health, the national longitudinal study. And we did multivariate regressions to see if we could measure the relationship between young people's health and incarceration duration. And so what we found was 14% of this national sample have reported ever being incarcerated. I'm going to just go a little more quickly through these slides. I just want you to see that we found a significant relationship between duration of incarceration and a higher relative risk of general health into adulthood. So this is young people's youth incarceration compared to health status when they were in their 30s, as well as with adult functional limitations and depression. So duration of incarceration was significantly associated with higher rates of depression into adulthood. We're almost starting to see a dose response here. And the prevalence of, or the relationship between duration of incarceration and adult suicidality was also very striking. Sorry, I keep losing the cursor, but any duration of incarceration was associated with suicide. It was this greater than 1 year that was statistically significant. The trend was present for all of them. So the study showed that youth incarceration was independently associated with worse adult health. There was a lot of anecdotal data. We think incarceration is not good for people, but it was pretty striking to be able to show this with national data that incarcerating a young person was associated with increased risk of worse health into adulthood. So Tyler asked me to talk about my future work, and Destiny alluded to it. Right now I'm studying reentry, a lot inspired by Dr. Wang's work and her leadership in this field. But what are the supports and services that can help young people succeed? And this is a photo of Twin Towers in Los Angeles County, which is one of our jails. And I feel I would be remiss if I didn't mention Twin Towers is a mental health jail, and it is the largest mental health facility in California. And based on what I've seen, as far as we can tell, it is the largest mental health facility in the United States. And the problem with that is that it is a jail. So again, I want to go back to that juvenile justice paradigm and thinking about the best interest of the child, and that this is really a public health issue. So with the last bit of our time, I just want to tell you about some of my work with looking at this youngest age of juvenile justice jurisdiction, basically the trajectory of my career. Once I figured out that justice involvement was such a problem, huge social injustices, harmful for health throughout the lifespan, I really thought, okay, well, how can we help keep kids out of the system? Who can we all agree with as a starting point doesn't belong in the system? And so partnered with people, and what we realized was that California had no law protecting young children from being processed in the juvenile justice system. And so this concept we learned is called the minimum age of juvenile delinquency or juvenile justice jurisdiction. I did this work in partnership with Laura Abrams at UCLA. And when we pulled the map from the NJDC website in 2015, we saw that California had no minimum age. The lowest minimum age at the time was 6 years old and still is. And Connecticut, you guys still don't have a minimum age, but I know that you're working on it. Your minimum age is 7. In 2017, I think 141 kids less than 12 in Connecticut were processed in the juvenile justice system. But in California, we were doing worse. So let me show you what we learned. Laura and I first did research like, wait, what? There is no minimum age in California. What's going on? And would a minimum age make sense? What has been said about this? So we did a literature review, and we kind of concluded the main points in the literature. Children lack the developmental maturity to comprehend or benefit from formal justice processing. So we're talking about the best interest of the child, but they're not going to heal. They're not going to rehabilitate because they're just too young. If you're thinking about a 6-year-old, a 7-year-old, a 9-year-old, and they don't understand what's going on. So you can't, we have standards nationally that we all agree on that say in order to process somebody fairly, they have to understand who their defense attorney is, what the judge is saying to them. But kids are just too young for all of that. Also, there's this principle that serving children, particularly young children outside the justice system, is more likely to be beneficial for the child and for public safety because of those cycles of future justice involvement, negative impacts on health. Kids just get stuck in the system, and their vulnerability just really increases. And there's United Nations and professional society standards suggesting that we should have a minimum age. The United Nations, at the time that Laura and I were started this work in 2015, recommended a minimum age of 12, and it has since increased. The UN has since increased the recommendation to 14. So the paradigm shift, it's ironically not really a shift because it's where we started, but seeing children as needing support rather than seeing them as criminals. In the last 100 years, we really got in kind of a bad kid, bad family, this kid needs punishment mentality instead of the, what does this child need and how can we help this child thrive? So we got data from the California Department of Justice, and we launched a study. What was happening? We found that the youngest child in California in the year 2015, for example, referred to probation was 5 years old. It was a Black boy referred for curfew violation. And that in this year, there were 687 referrals. And we interviewed stakeholders across California in many different stakeholder categories. And we concluded that a minimum age in California would address some, but not all policy gaps. So a step in the right direction, and that the charges were mostly for minor and nonviolent offenses. Most of the kids didn't ultimately end up convicted, but they did go through arrest and prosecution. So went back to the data. What can national data tell us about this? And we did a study looking at ad health, that national data set I told you about, where there were 15,000 adult participants. And we found that adults with a history of child incarceration, which for the study we just defined as incarceration less than 14. But before I go on, I'm just going to pause and say this term child incarceration, it didn't exist before we wrote this paper, which was really surprising. Like I Googled it in quotes, it wasn't coming up. Children do end up in the justice system. It happens all over the US. And by children, I mean young children at alarmingly high rates. But for some reason, people had not been talking about this. I think we all just kind of assume that that's not something that happens. But what the national data showed us was that children who had been in the justice system, or adults who had been in the justice system, were disproportionately Black or Hispanic, male, and from lower socioeconomic strata. And we also found that there was a connection between child incarceration and worse adult health in those same set of outcomes that I showed you previously: general health, functional limitations, depression, and suicidality. And so here it is, just if you're interested in the values, and the asterisk, these indicate statistical significance. So people in this child incarceration category were disproportionately male, disproportionately Black, disproportionately from families with lower household income, disproportionately lower parental education, and the rates of single parenthood were just much higher. So they were less likely to be in a 2-parent household. So, and then this is the data, the numbers around what I shared. So there was association with functional limitations or mobility limitations, child incarceration. So here's our child incarceration row, and here's the mobility limitations. child incarceration was also associated with adult depression and adult suicidality with a big fat odds ratio close to 4.5. So this was part of a series of studies that Laura and I did. Our next study, we did a 6-state comparison. So at this time, people weren't really talking about the concept of a minimum age. It wasn't clear whether it would be good or not to have a minimum age or what the minimum age should be. We did know that the United Nations had their standard of recommendation for minimum age of 12. There was some parallel work happening in Massachusetts also. And so then Laura and I did a 6-state study, and conveniently, it was a qualitative researcher's dream. It worked out that the 6 largest US states, 3 of them had minimum age laws and 3 of them didn't. And what was notable was that the states that had a minimum age statute, so for example, Pennsylvania with 10 meant that no child 9 or younger was processed in their system, those had been in place since their juvenile justice system was chartered in the 1900s. So this wasn't part of the juvenile justice reform movement. This is just how it had always been. So when we talked to people in Texas and we called them and said, okay, tell us what happens when someone who's 10 and a half, comes into your system, they would say, what? We don't get kids who are 10 and a half. They go to child welfare. And child welfare isn't always the correct response, but that was what our interviewee said. And then our comparison states were California, Florida, and Illinois. And we did legal analyses. We analyzed juvenile court data just to look at the rates of young child involvement in the justice system. And then we did stakeholder interviews with police captains, probation chiefs, judges, district attorneys, public defenders. And what we found, everybody agreed that the juvenile justice system is not suited for children. People felt that it was harmful for children, that it was not developmentally appropriate. The probation chiefs had very specific concerns, like, I don't know where to house them. I house them with my developmentally delayed kids. The clothes don't fit. Also, people said felt the system should protect kids from formal court proceedings. I felt that the court proceedings were harmful for the kids. This in states with minimum age laws, children below the minimum age threshold did not come into contact with the justice system. So this is a really important point. A lot of times when we pass policy, there's a gap between implementation of policy and what actually says on this, things say on the books. But in this case, we found that when there's a hard line of a minimum age law, then the younger kids just don't end up in the justice system, and that they receive treatment through other systems and supports when they needed it. And this is also a really important point, because another thing that we found in the study is that a lot of what was happening was developmentally normal, developmentally appropriate behavior was getting criminalized. In states without minimum age laws, there were some protections to protect young children from prosecution, but there were wide disparities in implementation of those protections. So for example, there are laws that say, if you don't understand what's happening in the courtroom, you're too young. Like, the judge will say, okay, we've just made all these decisions. Does this make sense to you? And the kid will say, when's recess? Like recess, like basketball, not recess from court. It's a sign that the kid doesn't understand. And so kids have protections, but there were always ways to go around those protections. So the stakeholders felt that a minimum age law had the benefit of fairness, but a drawback is the potential for net widening. So Connecticut's working on a minimum age of 12. One of the things we heard in our research and in working with advocates is that if you set the minimum age too low, it could actually be harmful. So if you set a minimum age of 9, for example, in a state that doesn't have a minimum age, it then makes it easier potentially to prosecute 9 and 10-year-olds. So with this work, we worked with very talented advocates, Patricia Song and Michael Harris with Children's Defense Fund California and with National Center of Youth Law, and presented our work with to Senator Holly Mitchell, who introduced legislation. She is an incredible politician. She put forward a state bill that ultimately passed that set a minimum age for juvenile justice jurisdiction. And my friend helped me write this actually. And so now California has a minimum age of 12 years old. So kids less than 12 are no longer put into our justice system. This is just a picture of some of the advocacy tools that Children's Defense Fund developed. These are teaching tools. These are not, what's very interesting on a sociological level is when you look at the advocacy that people develop, a lot of it are very simple teaching tools to just remind people what is a child's mentality. Like some of the other often used advocacy material says, you know, an 11-year-old is reading Diary of a Wimpy Kid. These are the things that they're thinking about. Let me just remind you like what an 11-year-old is like. So I didn't want to blurt this out too early. It was hard to save it for this point because this is such an important part of the story, but I wanted to save it for when I had the data to show you. So we did look at the racial disparity in California, and we found that Black children are overrepresented at every stage of justice involvement. But in particular, what's really important is that the Black children are even more overrepresented in the justice system at these younger ages compared to at older ages of childhood and adolescence, and that it's discretion at the early stages of the process that lead to the Black-white gap. So there's a carceral continuum that starts, there's decisions all along the way. Who gets arrested, who gets prosecuted, whose charges gets dropped, who has to stay for detention. And then that leads to then ultimately a judge deciding who's going to get convicted. But every point where there's a decision point is basically opportunities to for racism, for systemic racism, to disproportionately put young children in the system, which is a very important reason why minimum age laws are helpful. I haven't come up with a better way to say this yet, but there's like kind of like a foolproof way of making sure that the systemic racism doesn't reach kids below that minimum age threshold. So when you look at the numbers from California, we compared the referrals to probation compared to the US Census population of kids. And the Black children were way overrepresented compared to white kids, with our reference group, which had a rate of 30 per 100,000. The Black kids were referred to probation, kids less than 12, at a rate of 113 per 100,000. And that was statistically significant. This is just an example. I won't go over it in detail, but with the California law, each county had to develop a protocol of how they were going to respond to kids less than 12 that came to the attention of law enforcement. So the default in our legislation is to release kids to home. And unless there's basically a safety concern. So if there's an abuse or neglect, then you would have to call Department of Child and Family Services. If there's a medical issue, they go to Children's Hospital, et cetera. And then we also have ODR's Office of Diversion and Reentry that also then gets called to offer support. So we're getting closer to this best interest of the child concept. And one of the very important things that happens with this legislation is then pathways like this are developed, supports are put in place. And then as we're starting to see in California, the 12-year-olds and the 13-year-olds seem old. And then the system, starts working on how do we keep these kids out of the system also. Well, this is Destiny. So Destiny, I hope you get some questions that you get to answer about this. But now instead of incarceration, we're looking at arrest, which is child arrest, which is a larger number of kids. It's earlier in the pathway, and kids are much more likely to get arrested than to make it all the way through the pathway. And not surprisingly, the data is showing the relationships we would expect to see. I'm also studying the implementation of Canada's minimum age law. So Canada has a minimum age law of 12, and it's just amazing. I hope to be able to export this paradigm that children that come to the attention of law enforcement are truly viewed as children in distress and children that need support. There are some funding challenges, but the stakeholders in Canada feel that a minimum age law works. So the reason I'm talking about this is because I believe the US would benefit from a federal minimum age law. Karen Bass's office has proposed a federal minimum age, has introduced a federal minimum age of 12 for the federal justice system. There are no kids less than 12 in the federal justice system, but I think it's still a very important symbolic step. We have been so lucky to partner with the National Juvenile Justice Network, NJJN. They have taken on this issue of raising the minimum age as a policy platform. We have now Twitter handles, hashtag uncuffed kids, hashtag raise the floor. And this is a policy platform document. If anyone is interested, I recommend looking at their toolkit. And there's also monthly coalition meetings about this topic. And this is a slide. Oh, here are our hashtags: uncuffed kids, hashtag minimum age, hashtag raise the floor. There was a recent arrest of a 7-year-old that got attention. A 5-year-old that was handcuffed and berated. And in one of the interactions, a police officer shouted at a child, you're acting like a child. And the girl shouted back, I am a child. So is there a better way? Can we uncuff kids? So if you haven't seen this, it's worth, even though I've known this for years, even just looking at this on a map, this is a map published by the United Nations of the member nations that have ratified the UN Convention of the Rights of the Child. And so 196 countries have ratified it and one has not, circled in red. And one of the protections in the Convention of the Rights of the Child is a minimum age of 14. So can we get there? There's been a tremendous amount of advocacy. Thank you everyone in Connecticut who's been doing this important work. This map has changed so much since we started in 2015. It's changed so much since we made this in 2020. Destiny knows because she tried to update the map. Destiny wrote 2 great editorials. One was in JAMA Pediatrics and one was in the Journal of the American Academy of Child and Adolescent Psychiatry. And it was a challenge to keep up with the map because it kept changing. So I'm happy to answer any questions. I'm wondering about how best to measure implementation of minimum age laws and, does a US national minimum age make sense and how can we get there? And most importantly, for the young children, for all children, and even for adults, how can we best support people in distress so that they can get the support they need to thrive and ideally to be successful out of the justice system. So I would really like to thank the Yale Center, SEICHE, for Health and Justice for the invitation, the Tow Youth Justice Center, the Connecticut Justice Alliance, Destiny, and my many research partners, and I'm happy to answer any questions. Thank you.
Thank you so much for all of this. I know a lot of this from talking to you, and yet still seeing and hearing all of it makes me still feel very fired up and ready to do things to make it better. So I would like to open it up to our audience to ask questions in the chat or in the Q&A box, or to use the raise hand function for if people would like to be unmuted. And yeah, I just wanted to say I appreciate you for sharing that whirlwind tour of the world of juvenile justice and health. And I think I see that we have a question. So are we able to? Perfect.
Oh, hi. I'm Stacy Cabasa-Cali, and I work at the New Milford Youth Agency, and I run a juvenile review board. And we now get truancy and juvenile cases. I know we're trying to get rid of the word juvenile eventually, but we just don't have enough. We know that there's mental and physical health needs, and we don't have enough resources still. So is that help coming along soon? Or I'm wondering, I'm thinking that we need more recruitment of social workers that can work crazy hours. We need to boost the ones that are already in existence that that are available and are wonderful, but don't have enough help. DCF seems like they can use some help. So just wondering, what's going to be some immediate help for us before it's too late for some of these kids? Thank you.
Stacy, that's a great question. And I really believe one of the things we did in California was our minimum age law had delayed implementation. So there would be time to put in, so the law was passed and then later took effect, time to put in those supports. This is about reinvestment. It's not about taking away a source of support from kids. This is about putting the money where it should be to support communities, to support more health, more education. As you know, as I thought about this issue more and more, this is really about where does a society decide to put its dollars. And so I think that you have great insight. It's clear that these kids need support, and that if their families and the communities have the support they need, their ACEs might not be as high, and there could be a lot of prevention that happens as well. But you're right. And we need a lot of collective voices talking about that. We need the kids out of the justice system and where the reinvestment needs to be.
Exactly. Thank you so much.
Yeah, thank you.
We have another question about whether there are comparisons to any other countries that you could point out as far as how the juvenile justice system varies from place to place.
Yes, that's a good question. So I really recommend that NJJN report. I will try to put up the link if I have a time, but they have a great table that includes the minimum ages in other countries. And it was actually sitting around a round table with Laura Abrams. She's the professor, department chair of social welfare at UCLA. She's the one who said, hey, why don't we look at the lower age? And the reason she had that idea on her mind is because she was doing a sabbatical and was studying, looking at other countries. And she had just been to Finland. And Finland is a welfare state, and they do not have a juvenile justice system. So even just stop and think about that for a second. Finland does not have a juvenile justice system. Any child less than 15 who comes to the attention of law enforcement is viewed as a child who needs support. And then they would get community-based services. And then at 15 is the youngest age that it could potentially have some sort of justice involvement. So there's a lot to be learned, I think, from other countries. I think in the United States, we tend to be very isolationist because we kind of think we're the best. And then juvenile justice policy happens often at the state level because there can be the feds control how the money flows, but it's state law that determines criminal justice policy. And a lot tends to happen in isolation as well. So this is why the work of the National Juvenile Justice Network is so important in this powerful putting other states, like we'll be on calls and someone from Texas will say, hey, do you have any advice on this? And someone from Illinois will say, well, what we did was this. So a lot to be learned from other countries, a lot to be learned from other states. Feel free to reach out again. I'm happy to share our analyses from Canada. I think that they will be very relevant and helpful. I hope they will be. And there are many countries that are doing a lot better than us.
Thank you. There's one other question about are you familiar with the Vera Institute Restorative Promise projects that are related to youth 18 to 25 that can avoid prison? Thinking about whether that could apply to some of the other populations that we're thinking about here.
Yes, so there is talk about increasing the juvenile justice system at the upper bound. You know, when we wrote the legislation in California, the legislative office actually made an error, and they put the legislative office is the office in the Capitol building that like types up the bills and makes sure that they're in line with the Constitution, and they put the comma in the wrong place. And the implication was that it would have changed the jurisdiction of the California juvenile justice system to exclude less than 12 and to include 18-year-olds. Right now it's for offenses committed at less than 18, but it's another very important area. It's not my expertise, but I guess I should say, because the juvenile justice system is harsh. It is very hard on kids. but it's not as bad as the adult criminal justice system. And having kids in an adult facility is egregious. And I think that there's also a lot of potential opportunity for having transition age use in the juvenile justice system, particularly as and if we're able to get closer to that best interest of the child standard.
Great, and I think we have time for this one last question. It's so inspiring to see how you were able to translate this research to direct action and work with Holly Mitchell's office to make substantive changes. Do you have any advice on how to most effectively disseminate research and best practices and to engage policymakers?
Anna, thank you for that question. I've written an article about it, and I'm happy to share it with you if you reach out to me. And it's like a side project on my side project, because it's been so striking the extent to which, I mean, Holly Mitchell is an exceptional politician. Most politicians are not as great as she is, but I've interacted with a number of offices. And what I have found is that policymakers are hungry for research evidence, for researchers who know how to keep their message short to one pagers and to help give them the policy relevant information when they need it. So I would be happy to talk more about that. But my main message is reach out, because policymakers want to hear from you.
Great, and I'm putting a link to the perspective piece into the chat, the one on how you connected research to practice. And I also shared the NJJN policy document as well.
Thank you.
No problem, happy to do it. Happy to be a part of this. And I really appreciate you, again, sharing with all of us and answering all of our questions. And I imagine that many people will be reaching out to you to get more information, because this has definitely been really inspiring and hopefully will move us forward to action.
Destiny, I'm so glad that our one conversation led to you becoming involved, because you have helped so much. And there is so much shifting that needs to happen. For those of you whose work doesn't sit mainly in juvenile justice is just such a powerful amalgamation of the social injustices and a powerful lever to make change from. And it's going to take a lot of people from many different angles. So, so great to see so many people interested. Thank you so much.
Awesome, thank you. And thank you everyone for attending. Bye.